a child psychiatrist, and and I'm being blinded momentarily. And up until just a few weeks ago, I was the medical director at Jefferson Hills, which is a child and adolescent two treatment centers, one in long-term residential care and one in acute care, more like an inpatient unit, one in Aurora, one in Lakewood. Prior to that, I was the medical director for the Psychiatric Emergency Service at Children's Hospital, and currently I'm working interim part-time seeing patients, which I really love, at a residential treatment center. So I want to talk today about how to assess risk in youth. I have a little backstory there. So I have objectives there. You guys can read that one. So what is the problem? What is it that we're trying to assess? Adolescent suicide. Suicide is the second leading cause of death for children age 11 to 21 in the United States. More shocking to me always, 1,000 teenagers in the United States every day attempt suicide. That's real. So here are some numbers related to that in terms of what percent of kids consider, plan, or attempt suicide. You've got girls versus boys here. And the fact is, we're looking at 17% of our girls are thinking about suicide. That's not a small number. 90% of youth who commit suicide have mental disorder. I don't think that's Sorry. I'm sorry, I forgot you're videoing. I haven't ever had to hold a mic before. 11% of children, 10 to 19, suffer from a serious mental disorder, and of course we're including depression in that. And 8% of U.S. youth have major depression in the past year. The problem is nearly 70% of mentally ill youth are not identified, and even more do not receive any mental health services. So this is a map, I like pictures, a map of the United States with at least one major depressive disorder episode in the past year. I took out a lot of slides that showed more map stuff, but one thing that we will see is we're looking at these maps in terms of high rates of depression and suicide. There's a Rocky Mountain effect, and we see the Rocky Mountains highlighted in terms of suicide and depression. So what happens when we don't treat mental illness in youth? They kill themselves. That's what happens. It's not the only thing that happens, but it's one thing that happens that's significant. And we can see little kids don't kill themselves as much. They're not good at it, and they don't know how. The older they get, the better they get at it. But 1,000 teens are trying every day. 17% of girls are thinking about it. It's not a small problem. So stinking child and adolescent psychiatrists, why aren't they helping? Why aren't they doing more? Stinkers. This is a true problem in health care, and the attitude of primary care providers at frustration beyond compare with mental health professionals, particularly psychiatrists and particularly child and adolescent psychiatrists, is severe. It's a barrier to care. Only 20% of children and adolescents with any mental health needs receive mental health services. Of that 20%, a small fraction will be treated by a child and adolescent psychiatrist. Why? We have a serious shortage of human bodies who want to do child and adolescent psychiatry. We have less than 7,000 in the United States today practicing clinical care. We need about 40,000 based on the estimates that we've seen. I will caveat that if we're going to keep practicing the way we've always practiced. Now, it is possible that through training more people, we'll have thousands and thousands of physicians who say, I want to go 6 years. I want to work with kids and families. The chances are high, not. The first thing everybody says to me is, oh my God, I'm so glad you do that. I would never do that. Everybody. It's pretty shocking. So, there's also a severe maldistribution of resources. Where are these child and adolescent psychiatrists located? They are located in urban areas, by training institutions, and by, shockingly, children's hospitals. So, you have a consolidation. There's another maldistribution based on who pays. So when your providers are so short, then you don't have to take Medicaid. You don't have to take anything but cash. And that is a real deal problem in child psychiatry specifically, because rich people's kids are suffering too. That's reality, people. So if you're taking Medicaid, you're working in an institution or you're working with this population by choice. The majority of counties in the United States have no child and adolescent psychiatrists. My map. Blue means none. None. These are counties. It's a bad situation, and it causes a lot of strain on the front end of network provider services. Here's Colorado. So we do have counties. You can go, oh wait, here's Children's Hospital, right? You can point to where the hospitals are, where we've got mental health centers who specifically employ providers. It's always going to be the same. Here, I flew to Montrose here, and I served as point 2 of their child psychiatry. But gets them on the map, right? They're not their clue. They've got another provider there as well. So what is the impact of not none, but limited providers in terms of subspecialty providers? A health affairs study reported that pediatricians were, and I had a typo here, but were less likely than other primary care providers to refer for mental health services. Why? Because they can't get any. And they're sick of asking, and it's frustrating. Why aren't the child psychiatrists doing more? I'm telling you, it creates problems in the system, that level of frustration. It's part of why it's so important for me to give some numbers around it, because it's not because we don't want to help. It's because the way we do medicine now can't let us serve the best we could, I think. And we need to make changes around that in a longer term way. So, the bottom line is, when you do refer to a child and adolescent psychiatrist, the average wait time is 7.5 weeks. So, that is somewhat of a problem, because this is a child. And you go from 6 to 6.5, oh my God, it's huge. 2 months in a child's life is a lifetime for us. And a lot can change in that period of time. So somebody got to see them. So who is seeing these kids? Who is helping them? You are. You are seeing them and helping them. Because I'm only seeing this many. Who it is mental health care providers are the primary care providers, whether they're family practitioners, pediatricians, general internists, physician's assistants, nurse practitioners. General psychiatrists do see kids, rarely below 12. If you've tried to refer, you know that. Mental health clinicians see everybody. And those can be licensed professional counselors, psychologists, social workers, case managers. So, what are you going to do since you already know you got to see these kids? They are showing up, and even when you refer, it's going to be a while. Then we look at risk determination. How dangerous are they really? What is happening here? We'll go through these factors. So first, you stratify your risk levels, right? Low, moderate, or high risk. And that's going to determine what you need to do with this patient. Same as every other area. Whether you're in mental health, physical health, it's the same. Where's their risk? Do your risk assessment in terms of how urgently do they need assistance. So what are the risk factors for youth suicide? Primary risk factor for all groups is untreated mental illness. 90% of people who die by suicide have a mental disorder. Stressful life events clearly are risk factors. And when you have a stressful event, then that can precipitate a depression, and the depression itself can feed the blah, blah, blah. So there's a lot to be mixed in here. Same as with all healthcare. So what are the specific stressors that increase suicidal risk in children? Impulsivity. It's your enemy. And all kids are impulsive anyway due to their brain not being cooked all the way. And impulsivity is a major risk factor for all suicide. Prior suicide attempts, family history of suicide, gives a kind of permission in some ways to families, and kids especially. And they also can have a feeling they want to join that family member. Access to firearms, extremely big problem, particularly when coupled with impulsivity. History of physical or sexual abuse has a huge impact. You're increasing your risk factor for suicide by 5 to 7 times. Bullying, I'm telling you, the child psychiatry calendar follows the school schedule exactly. We do not have an uptick in kids at Christmas. Are you kidding me? Santa's bringing them stuff. No, wait. They're chilling out. Their parents are trying to chill out. We have a certain population that isn't happy at Christmas. They're children in foster care, kids who have a crappy situation. But typically, kids are mellow over the holidays. It's adults who are getting drunk and showing up in the ER. It's true. I'm telling you, it's the opposite. It's the opposite. Kids sleep during the night. Adults are in the emergency room. It's the opposite. And then any kids with sexual orientation or gender identity issues, much higher risk for suicide. Exposure to suicide previously, other kids, friends committing suicide, legal involvement, and then substance abuse, which I come back to impulsivity. When you're drunk, you're more impulsive. And that goes for adults as well. So suicidal ideation. Ideation is thinking about suicide or planning suicide. Suicidal ideation, as we saw, is common. 17% of teen girls in the United States. Suicide attempt, any self-harm attempt when someone is expressing the intent to kill themselves. And with kids and adults, this is different than cutting. And that is a really scary assessment to be making in your personal office when you got someone with marks on their arm. Oh my God, how suicidal are they really? So, suicide risk factors endure over time. We can do risk factors all over the place. We're just doing risk factors. Being a male is a significant risk factor. Women kill themselves. So risk factors don't tell us about imminent suicidal risk. What are the clearest warning signs of suicide? Looking for ways to kill yourself. Having a well thought out plan. I'm going to put this pillow over my face. That's my favorite plan. I'm going to use this rope. That's my least favorite plan. So what are they planning on? What are they thinking about? Talking or writing about suicide. Kids post on Facebook. Kids text each other. And talking or writing about death in a way that suggests preoccupation. These referrals come from teachers. A huge portion of our referrals come from schools. We follow the school calendar. So risk factors versus risk assessment. Majority of teens and humans thinking about suicide will not kill themselves. Who's it going to be? We actually suck pretty bad at predicting which person it will be. That's just not part of what we do well in medicine. So what's keeping people alive? That's another thing you need to be thinking about. What are their protective factors? So we know if they intend to die, they have a plan, and they have a way to do it. That is a serious risk factor for suicide. If they've got protective factors, I don't want to leave my mom, I don't want to leave my family, or if they're afraid for their religious reasons that there'll be repercussions for that, it can be very protective. These are questions to ask. So we're going down through risk assessment. First, emergency management, when you got a high-risk person, they've got a plan, they say they want to kill themselves, you're done. They need to go to an emergency room. When you're in your primary care office and you're getting this information from them, you don't need to tease it all out. I was very happy with Sherry's talk because I did not know you could call Metro Crisis Line from the office. Do it. That's a great idea. I love that. If you've got a high-level case and you're not sure, man, when in doubt, send them out. That's my motto, and it always has been. When in doubt, send them out, because you don't want to be in that situation. And I've talked to enough primary care providers who work in the emergency room where they don't want to put the family, this and that. Look, man, a dead kid is more hassle than anything else, really. And you can talk to parents that way and help them understand the seriousness, because even if that kid doesn't want to kill themselves today, they want you to know they're suffering. Pay attention. Don't make them up the ante. So, if you have a more moderate risk where they're not imminently suicidal, but you can tell they're depressed and something's going on, you can continue assessing that. You can work with the family, give them a mental health referral, and then see what happens next. And just keep watching them. Have them come in just for a well-child check. Keep checking in on them. Low risks, follow-up visits, a non-urgent referral to a mental health specialist, and then you can continue monitoring. How do you ask? People are afraid to ask about suicide. I'm going to give them the idea to kill themselves by asking. No, you're not. You're not. They've already thought of it. They've already had friends who are doing it. They already know about it. You do not cause suicidality by asking. You relieve an internal pressure. It helps them. We've had good data around this, and it has been recommended that all teens be screened routinely by primary care providers. So, I have two screening tools here, and Dr. Nordstrom's going to talk about the adult version of the PHQ-9 some. These are simple tools. This PHQ-9 is specific for working on mental health, specifically looking at depression screening. There's a shorter version for when you're looking at just safety issues. Do you wear a seatbelt? Have you been immunized? Do you chew tobacco? These are simple screening tools you could use in any primary care office. And when you get that check mark, have you thought about killing yourself? Or you're concerned about any of these questions, have you thought about, this says ever thought about suicide? Perfect time for a conversation. And again, if you get stuck, call Metro Crisis Services. I am all about that. That's fabulous. And this is more on the teen screen. This used to be an amazing resource, but it got shut down when they lost their grant. Columbia University put it on. And I still have a bunch of tools from them, but they do still have free access tools online and some training materials. You can incorporate in any way you want into your practice how to ask, but not asking doesn't mean you're not going to have problems. It just means you won't know till later. So, refer for mental health services when a child or adolescent demonstrates an emotional or behavioral problem in which there is evidence of significant disruption in day-to-day function, basically when it becomes disorder. There's only a partial response to psychotropic medications, or they're needing multiple medications. It's getting more complicated. They have a chronic medical condition and it's interfering with treatment. Diabetes. Big problem, diabetes and suicide. They always have the lethal needs. When they've been hospitalized and when they have significant issues and their primary caretaker has significant mental health issues. What are we going to do with all these kids? We're screening, and now we've identified they're all suicidal. So, after your risk assessment, you need to go to referrals. Question number one in mental health is who's paying for this? So today, since we're talking Medicaid, Medicaid's paying for this, and I actually have found that Medicaid services give kids much faster access to mental health care. Maybe not to a psychiatrist, but to a mental health clinician who can assess them and refer them. You still can have a pretty long gap before seeing a psychiatrist, but not always. So here's our Colorado Community Mental Health Center system and who represents you. And then here I put them in, oh, that's great. So then we've got all of your contact information for who each mental health center system serves. What I would recommend personally is get to know the people in your mental health center system. Get to know a contact person that you can refer to, that you can even have a little, hey, can I chat with you for a sec? We've got this kid here. We're all in the same system, right, within the RICO and within this Medicaid pool of patients. Ideally, we'd be working together to help these kids and families through these crises.